This edition of the Bio Report is brought to you by the California Technology Council, providing discounts on products and services essential to every startup. For more information, visit californiatechnology.org/member benefits. I'm Daniel Levine, and this is the Bio Report. The ability to find in circulating blood cells and DNA fragments shed by tumors has given rise to liquid biopsies. This emerging area of diagnostics promises to improve cancer care, better monitor patient response to therapies, and provide earlier evidence of recurrence. We spoke to Andre de Fusco, CEO of Cynvenio, about the company's liquid biopsy rare cell isolation platform, its implication for changing how cancer patients are diagnosed and treated, and the promise it holds for improving outcomes. Andre, thanks for joining us.
Thank you, Danny.
We're going to talk about Cynvenio and liquid biopsies and precision medicine. This area of liquid biopsies has been moving quite rapidly, and it's a promising development for a number of reasons. Perhaps you begin with what a liquid biopsy is and how it works.
Sure, I'd be happy to. So liquid biopsy has emerged over the last 4 or 5 years as a alternate way to sample patients in oncology, or as a complementary way to sample patients that have been initially staged with tissue biopsy. So whereas tissue biopsy involves the removal of cells and their subsequent analysis by histopathology to determine the nature of somebody's cancer or the progression of their disease, liquid biopsy purports to do the same, but using biological samples that are, for example, blood or urine, or as the name implies, liquid, something that can be sampled dynamically from the patient, but not using tissue.
Well, we've been in a period of rapid technological evolution. What's happened from a technology point of view that's enabled all of this?
Well, a number of things, I would say, but probably the most significant is the advent of lower cost sequencing platforms. And by that, I mean devices that are in the $100,000 to $200,000 range, as opposed to the several $1 million just a few years ago. There are many ways to do the molecular characterization of tumor cells or cell-free DNA, but I would say that the advent of affordable, quote-unquote, and easy-to-operate sequencing for the analysis of DNA and RNA is probably the single biggest contributor to this boom that's going on.
Liquid biopsies would seem to provide some advantages over traditional biopsies. What are some of those?
Yes, that's a very good question. So I know we've all heard of companies out there that are saying that the liquid biopsy should replace the tissue biopsy, and so forth. I happen to view the liquid biopsy as complementary to tissue biopsy. I think it just happens at a different time. You can imagine a breast cancer patient, for example, when they are first staged or diagnosed, tissue biopsy may be done on the tumor in the breast. That tumor is then removed. And if you wanted to measure that patient or test that patient longitudinally months later or even years later, you would not have that tumor tissue to go back to. So it's important to have an alternate template. And in our case, we use blood for that. So I think liquid biopsy represents a longitudinal monitoring opportunity or testing opportunity, whereas tissue biopsy is perhaps a snapshot in time that is done once or twice and represents more complexity and more risk for the patient.
And one of the things that makes all this possible is the fact that tumors shed either cells or DNA fragments that circulate in blood or urine. Some liquid biopsies rely on circulating tumor cells, others use DNA fragments. If I understand it correctly, your approach actually relies on both. Why is that, and what are the limits of using one or the other?
Yes, I think that's a key point right now in the industry. Each company, I guess, touts their own approach or their own technology. We come from a clinical background where we did not start with tissue biopsy or a priori knowledge of the patient's clinical assessment. So we actually sequence three templates simultaneously. We look at germline mutations, and then we look at somatic mutations in cells or circulating tumor cells or complete cells that are found in the blood that are generally thought to have sloughed off whatever solid tumor the patient may have. And we also look at cell-free fragments or cell-free DNA or circulating tumor DNA, which has come up more recently as a viable template. We see different things in the different compartments, and we think all three together provide a better picture. We also use the germline sequencing to provide, we call it case control sequencing, but it is a way for us to make sure that we are not calling out mutations that are in fact irrelevant to that particular patient situation. I think cell-free DNA testing tells you different things about the disease at different times. And I think ultimately, if you could obtain a viable cell, there's much more information that the cell can yield. And then beyond DNA, which is where we do a lot of our work, RNA, that you can only obtain from a cell. So that's why we have this multi-template approach, as we call it.
Liquid biopsies rely on finding what's been called rare cells. I mean, given the volume of blood, there are very few of these cells in say, a sample. What are the challenges to getting liquid biopsies to work and provide actionable information?
Well, there are. I think the very first challenge is that one has to use an enrichment system to obtain the cells. And we have a very strong technology background in that at our company. And there have been other companies over the last 15 years that have also developed approaches. But I think what that introduces is bias. So you can have, whether it's a positive selection or a negative selection systems, depending on how you're selecting for those rare cells, you can have bias. And by that I mean you will find only the cells that display certain surface characteristics, or you will find cells that are at a particular state, but you may not be able to detect when they mutate or when they go through a mesenchymal transition that makes them a more dangerous cancer cell. The beginning of metastasis, for example. So I think companies that have had a hard time harnessing this type of enrichment step. And there have been very few, if any, that are compatible with downstream analysis methods like sequencing that require certain levels of purity. At our company, we believe we've solved both sides of the equation. So we have the enrichment technology, and we have a process that is entirely compatible with sequencing or PCR without amplifying the results that we get from our platform. But I think that's been a barrier for a lot of companies. The initial enrichment step, they don't obtain enough cells, and they probably do not obtain the right cells, or at least they think they have a cell that's relevant, but it turns out not to be the molecular target they're looking for. So I think that's stymied the field, but that's something that we believe we've overcome.
You mentioned earlier that you see this as being complementary to traditional biopsies. How do you see these tests being used? Is it for initial diagnosis, monitoring the benefit of a drug, or monitoring for recurrence, or is it matching the right drug to an individual patient's cancer?
Well, it's Danny, it's all of the above. Those scenarios that you just described happen at different points in time. The reason I don't discount the tissue biopsy is because of the heterogeneity of cancer specifically. So there is so much to be gleaned, by sampling different parts of the tumor. If that's being done anyway clinically, why discount that? So we would make use of that. My interest is generally in the longitudinal nature of the testing opportunity. So if somebody is assessed and then can be tested weekly or monthly to see what their molecular response is to a particular drug, doctors find that attractive. There's also the opportunity to see the rise of resistance mutations, which of course everybody finds attractive, including the patient who doesn't want to stay on therapies that are not working for them. And then I think a neglected area in the field is surveillance later on, maybe in the period of a year or two after somebody has completed their treatment, to make sure there is not a recurrence, or if there is, that recurrence can be spotted and characterized early enough that something can be done in terms of treatments. So I think it really applies everywhere.
Well, you have a variety of products. I thought maybe we could walk through those and how they're used. First, you do offer a liquid biopsy testing service. Is this for a specific cancer, or does anything go?
Well, no, we tend to focus on 4 types of cancers: breast cancer, colorectal, prostate, and to a lesser degree lung, because lung is an area. It's a test that we're going to bring up later this year. But our lab does provide those types of testing services today experimentally, and it also supports clinical studies that we have in triple-negative breast cancer and colorectal and prostate cancer that we do in partnership with research centers in different parts of the world.
You also have a test, Cleared ID. How is that used?
Correct. So Clear ID is used mostly for breast cancer, and it can be ordered by physicians or other institutions that are getting ready to deploy our workflow. And when they're comfortable that this is working well for them and their patients, their doctors, they can deploy everything inside in their own labs. They can buy the equipment from Cynvenio or Thermo Fisher Scientific and get trained up and make this part of their in-house workflow. So it's not just the send out to Cynvenio, is what I'm trying to say there.
How about NKView? What is that?
And NKView is a different test. NK stands for natural killer cells, and we use that to monitor or measure the health of somebody's NK activity, which is tied to their immune system. So if somebody has high NK levels, they have a very strong and active immune system. If they have low levels or dropping levels, we tend to reflex the sequencing. It's a test that comes from a partner company in Korea. It's approved in Canada and Korea, and there's a link between NK cell activity and certain types of cancer. So we use them both together. The NK test is being used also in the triple-negative breast trial that we're doing here. So patients get tested for both.
What have you done to validate the liquid biopsy, and is that important to gaining acceptance among doctors?
Yeah, I think it's very important to validate, not just liquid biopsy, but all these tests. Tests that rely on sequencers at some point have to be normalized. You have to make sure that the test that's coming off an Illumina sequencer is the same result that comes from a Thermo Fisher sequencer, and it's the same result that comes from a QIAGEN sequencer, et cetera, et cetera. And I think the industry is sort of a little bit at the beginning of this cycle. We have case control sequencing in all of our samples for that reason. So now over the better part of 15,000 samples, we have a very good handle on what is machine noise and what is in fact a true biological signal. But I think in the next couple 3 years, there's going to be a lot of focus on that. And I think our approach, will pass scrutiny. We also use software that is extremely transparent. It's possible to analyze exactly how we make calls, and it's done in an automated fashion. So we don't leave anything to the discretion of an operator. There's no human intervention. So I think that's important as well.
And is reimbursement an issue at this point?
And reimbursement is an issue in this industry, yes, partially because there's not enough clinical utility data for the payers to, I'd say, really understand what the technology does. There are all sorts of debates going on about outcomes. A lot of this in the diagnostic area, as I said, is uneven. The answers are uneven lab to lab, which has to get resolved. But I think mostly it's the fundamental clinical utility data that is lacking or has not yet been presented in a way. There's concordance data between liquid biopsy and tissue biopsy, and there's repeatability and all that kind of sample to sample type of data within the labs, and many of them are operating as CLIA labs, CLIA CAP labs that are regulated. But there's little in terms of clinical utility showing how the test influences treatment, or showing how that treatment influences overall survival, or things that the payers would would normally like to know before reimbursing.
So is this going to require you to do clinical trials that are more akin to what a therapeutic would have to go through to establish that?
Yes, exactly. So at Cynvenio, we're spending most of our time on clinical utility issues. And some of that is the technology, but most of it is working with 5 different cancer centers in different indications and supporting them doing trials exactly as I described.
And how are you funding that?
We're funding it ourselves. So we raised $25.5 million last year, and a lot of it is going towards supporting these trials.
So it seems that these tests are going to enable a very different approach to treating cancer. How significantly do you see this changing the landscape for cancer care?
Well, I think it is fundamental. It's a fundamental shift in how patients are diagnosed. I think it's a fundamental shift in how people eventually will be measured and treated. And, I think it's a low risk approach, which I think is great. That can be done in blood. Peripheral blood draw is not a high-risk procedure. I think it has to go mainstream. I mean, technology is always ahead of adoption, so we are right at the beginning of that ramp. I think we are sort of at the end of the beginning of liquid biopsy. We were talking about this 4 years ago, and everybody was saying that that would not be necessary, that tissue biopsy was enough. And I think now with the discussions around heterogeneity, people are starting to realize that there is much more molecular information to be gleaned by different forms of template, including blood. So I think that part of the argument is over. Now we're in the second phase, which is the early adopters, and showing how this can be used in practice, in clinical practice, and what kind of results that it yields. So I would expect this to be mainstream within 5 to 10 years.
Andre de Fusco, Chief Executive Officer of Cynvenio. Andre, thanks so much for your time today.
Thank you, Danny. Appreciate it.
Thanks for listening. The Bio Report is a production of the Levine Media Group. To automatically download this podcast each week, subscribe to our RSS feed or through iTunes or other podcast manager. To join our mailing list, go to levinemediagroup.com. We'd love to hear from you. If you want to drop us a line or are interested in sponsoring this podcast, send an email to danny@levinemediagroup.com. Special thanks to Jonah Levine, who composed our theme music, and the Jonah Levine Collective, which performs it.